Welcome. Thank you for joining Autism 200, Seattle Children's monthly autism lecture series. My name is Katrina Davis. I'm a family advocate at Seattle Children's Autism Center, and I'm the parent of a young man with autism who's 21 years old. Tonight's topic is nutritional considerations in children with autism. Before I introduce our panelists, I have a few announcements. This presentation will end about 8:30. It's being streamed via Facebook Live. We welcome you, our large online audience tonight. Tonight's presentation will be viewable online indefinitely, so you can watch it later or tell friends about it via Seattle Children's Facebook site. And you want to find that in the videos section. And we also upload all past monthly lectures to our Autism 200 YouTube playlist. So you can watch any and all of our past lectures. Simply go to YouTube and search Autism 200 and click View Full Playlist. You may have questions about autism and nutrition tonight as you watch this session. Please put your questions in the comments section, as we have left some time toward the end of the session to address your questions, and we'll do the best we can to answer everything. Tonight, we will have three panelists who will be sharing information and resources about common nutrition concerns seen in autistic children with selective eating issues. In the autism community, we have a lot of picky eaters and complex feeding concerns, which can cause tremendous anxiety and discomfort and even health-harming circumstances for individuals with autism, and a lot of fear and deep distress for parents who struggle to keep their child nourished. I'd like to welcome our speakers for tonight. First, we have Lisa Holman, Masters of Science, registered and certified dietitian. Lisa works at the Pediatric feeding program at Children's. Next, we have Lauren Mozer. She's Master's Public Health, registered and certified dietitian. She works at the Pediatric feeding program at Children's and the GI clinic as well at Children's. Lauren also works with youth and juvenile detention at 2 facilities in the area through adolescent medicine clinics at Children's. Third, we have Kim Nowak Cooperman, Masters of Science, registered and certified dietitian. She also works at the neurodevelopmental clinic and the neurology clinic programs at Seattle Children's. You should also know that a lot of the content and session material was made possible with contributions from Danielle Dolezal. She's a PhD and a board-certified behavior analyst and the director of the intensive feeding program at Seattle Children's Autism Center. Thank you for being here tonight, and I'm going to turn it over to Lisa Holman.
Thank you so much for that introduction. And again, just on behalf of Lauren and Kim and myself, thank you to the Autism Center for having us as guests. We're really excited to speak on this topic and be with you all tonight. And for those who will be watching it later, thank you so much for your interest in this topic. It's something that I think I can safely say on behalf of all three of us, we're really very passionate about. So it's really a pleasure to be here. Next slide. Tonight's topics are really going to focus on common nutrition concerns. And when we think about autism and selective eating, we really want to think about the nutrition risk associated with those concerns and other considerations for feeding challenges. We hope to address autism, ASD-specific diets, give some thoughts and input on how our team works together, and hope to offer contributions to how those in the community might be able to partner with their care teams. And throughout this entire talk, we're going to weave a case study that our hope is that it will illuminate some of the common concerns and presentations we see in children with feeding disorders or feeding difficulties. And at the end, we'll offer up some suggestions and some practices that our clinic uses around feeding that we hope will be helpful. Next slide.
Okay, so I will take over for a couple of slides. And one thing we want to talk about is the nutrition risk with children who have autism diagnosis. So we do know that many children with autism have feeding issues, and they can be described in many ways. Some descriptions have already been made: selective eater, picky eater, other names: problem eater, anxious eater, fearful eater. They can be described as selective, fussy, choosy. There are many other names that you may have heard yourself or used yourself. Children with autism seem to prefer starchier foods and snack foods, or maybe processed foods more often, and they might have a dislike for fruits, vegetables, proteins, and those types of foods, and which might possibly be because of the texture of the food or the food characteristic. Food neophobia is a characteristic in toddlerhood of normal development. However, this can persist and lead to more rigidity in children with autism. This type of food refusal results in an inadequate diet diversity, which is needed to provide recommended intakes for energy and essential nutrients. Next slide. Picky eaters with autism may not consume adequate amounts of several macro and micronutrients. They may not recognize their own hunger and fullness, and their response to hunger cues, can be affected by many things. For instance, interactions with the outside world, such as screens, eating environment, feeding dynamics. Those types of things may support or disrupt the recognition and response to these cues. We do have evidence that suggests a link between some dietary or circulating micronutrients and sleep, specifically, iron and magnesium have been studied. Children are at increased risk for dehydration if they do not recognize thirst and don't drink enough, and this can contribute to constipation, which is also relatively common. Children with autism can be overweight. The odds of overweight are about 1.6 times higher than in the typical population. But there's also a risk for faltering growth in this population. And then there's the children who are growing normally and look okay on the growth chart. And we see that often. And medical providers have a low concern, even though the diet diversity is poor, which can be frustrating. Next slide. Children with autism spectrum are at an increased risk for having a pediatric feeding disorder. That's what the PFD stands for, in case you were wondering. Some of the symptoms and outcomes are listed here. Food refusal is typically universally present, and there can also be difficulty with oral motor development. There are frequently sensory sensitivities to food characteristics and eating environment, which leads to rigidity and anxiety around eating and mealtime. And this happens for the children as well as the families. Caregivers, in their quest to help their child, have tried many strategies that may have included forcing or pressure in the past, which can worsen the situation. But we all know how stressful it is when your child won't eat. Outcomes can include very limited food and fluid acceptance that can affect growth, nutrition status, and development of appropriate feeding behavior. In some circumstances, a feeding tube or formula-based diet may be recommended. Next slide.
We often hear, "Why won't my child eat?" Or, "And my team's job," and Kim's team's job, our team's job is really to help answer that question. And we work closely with occupational therapists, speech language pathologists, medical providers, and our BCBA or psychology colleagues to really help answer that question. We're really working together to try and understand, why is eating hard for this child and what are the barriers? And this slide was put together by our team to really illustrate how complicated and interconnected these factors are. So beyond the nutrition, the psychological factors, the medical factors, and the skill, we really want to think about the interaction between the parent and the child together. All of these interact together and can create a cycle that maintains a child's learning that eating is hard or painful or scary. The literature and the research in this area has noted there are various factors that contribute to feeding disorders in all children, including medical concerns, oral motor, physiologic, and physiological. The most common factors are medical and physiological, or psychological, excuse me. Given there's so many possible contributors, it's important to really closely look at all these variables simultaneously to isolate what is impacting that child and family at this time. I think it's also really important to remember that eating is a really, really complex, dynamic process. So it requires multiple organs, it requires several muscles. For example, one swallow takes 26 muscles and 6 cranial nerves. It takes the coordination and integration of sensory systems. And after 6 months of age, it's essentially a learned behavior. Next slide. So to illustrate, as I mentioned earlier, kind of what this looks like or what a presentation might look like in our clinic, I'd like to introduce our case study. Alex, he's a 7-year-old boy. He is autistic. He presented to our clinic with sleep difficulties, chronic constipation, ARFID, which is an abbreviation for avoidant restrictive food intake disorder. He accepted small tastes of brand-specific dry, crunchy foods. He would accept Pediatric, a nutrition support formula from a bottle only, but not a cup. Alex would really refuse anything that was presented to him. It would lead to a lot of challenging behaviors, a lot of escalation, a lot of emotion around food and feeding. And parents, when they presented, just felt like we've tried everything. We've done lots of outpatient feeding-based interventions, and we're really feeling at the end of our rope. Next slide. A little more about Alex. These are the clinics that he had already established care in. So here at the Autism Center, he'd also been seen in neurodevelopmental. He'd been meeting with an occupational therapist, and he'd been seeing one of our dietitians in general nutrition clinic. And the summary of those recommendations was continued close management of constipation with GI, although he had not yet established GI, updated oral motor sensory evaluation, and outpatient therapy. And really the summary is just that there was ongoing multiple coordination between lots of clinics for this child's feeding difficulties. Next slide. We included this slide, which illustrates Alex's feeding history, because it's a really, really important piece of treatment to really understand the early eating and feeding history of a child. With a few slides back, looking at that pie chart of interdisciplines, we want to think about what factors might play a role in challenging eating for this child. And we know that often the initial stimulus that makes eating a challenge is not what sustains the refusal. So a child might have GERD or reflux when they're younger, and then they begin to associate that pain or discomfort of eating with the food. And, you know, they may be on a medication that resolves that discomfort, but that fear really remains. So understanding Alex's history can help us understand that process for him. And a couple of things that are really notable or kind of that stand out when I look at this is that, you know, from an early age, Alex was a child who was milk dependent and really has always leaned on dry crunchies as preferred foods from 1 to 2 years of age. Started experiencing chronic constipation at 2 to 3 years of age, and began working with a speech therapist. By 5 years, more team members became involved in his care. So working with an occupational therapist to really focus on meal timing and sort of optimize that biological hunger, which we know can be a piece of helping a child to eat. The dietitian was concerned about his intake, and so started him on an oral formula, Pediatric. And his primary care physician, or PCP, was started treating his chronic constipation and really encouraging things that can help resolve constipation: water, fluid, fruits, veggies. But for Alex, that was very aversive to him. And so with the presentation of a new food, he was screaming and gagging, wouldn't eat anything at school, so not able to sort of transition environments around eating. And parents are so worried about his intake that really anytime he would ask for something after school and after his nap, he was kind of provided with it. So he was really able to eat or graze on demand. And it was hard for him to fall asleep and stay asleep. He would wake up hungry with unresolved chronic constipation. And so by the time he presents to our clinic, off and on, he's completely refusing food, usually correlates with his constipation. His intake has come down significantly and he's losing weight. And so his PCP has started a new oral supplement, which is Pediatric, but this time a fiber Pediatric. Next slide. So for our team, it's really important to think about goals of care. What are the goals of care for the family? How can we support? And so for Alex's mom, she really just wanted her son to have some love and appreciation of eating and it to not be so fearful and not to be so much of a struggle. She wished he wasn't so dependent on that formula to meet his needs. And she really wanted help with his constipation, just because it had been such a hard thing for him. Next slide. When we looked at Alex's growth, it's bobbling around a little bit. And by that first bullet point says proportional, and proportional really meaning that that refers to his height and his weight. So he's growing, but we see sort of around 6 years of age, there's this kind of significant drop. And then a little bit of a slow, steady decline, but then he drops again. And so that really seemed to correlate with bouts where his constipation was really bad and his oral intake was going down. And really what that ultimately tells us is that his calorie intake is inconsistent. And again, we were seeing this acute weight loss associated with the constipation. Next slide. So when we looked at what a typical day of eating was like for Alex, this was the report. So he started his day at about 7 a.m. With a Pediatric. He drank really quickly in his bed, wouldn't come to the table, wouldn't come out of his bed, required to drink the Pediatric in the bed, and then requested a second one, usually pretty short order after the first one. And then would go to school, lunchtime. He would drink his chocolate milk, variable amounts, and then he'd have a dry crunchy, so some chips, again, variable amounts. It was difficult for him to eat at school. His afternoon snack was also at school, just a few sips of water and maybe some crackers. And he would come home and take his nap, and then he would snack all afternoon, a lot of times on his formula, a lot of times on dry crunchies. But as I said before, parents were so concerned about him getting enough that it really was sort of a feeding on demand, where he was really able to have what he wanted when he requested it. And then, as mentioned earlier, his sleep was really poor because of hunger. So several times a night, up to 3 times a night, he was waking up and asking for a milk and going back to sleep. And again, some of the behavioral presentation, we were seeing screaming, gagging, vomiting when presented with a non-preferred food, snacking, wouldn't sit for the meals, rigid routines, so very specific about the type of cup that his drink was presented in, the type of chips that were offered, and really sensitive to changes in texture and smell. Next slide. So the questions that we were asking from a nutrition perspective were really kind of looking at his growth. So is he getting enough? What is his interest in eating or focus? What does his schedule or pattern of eating look like? And what foods is he accepting? And is he able to drink enough or eat enough to really satiate himself for any amount of time? Does he have interest in new foods? GI function because the reported constipation and sleep associated with the hunger. So again, we're seeing inconsistent intake, Pediatric dependence, not a lot of biological motivation to eat, so a sort of a weak hunger, not a lot of interest in solids, really leaned into his preferred foods, kind of a low amount of focus on eating in meal times, really struggled to sit for meals, preferred to eat and drink in bed, small amounts, frequent volumes over the course of the day, not enough fluid or fiber to help with functional stooling, and a grazing pattern, which was sustaining his constipation and disrupted sleep. Next slide. And so that's our intro to Alex and a little pivot point, and then I will hand it over to Lauren. But just there was, this is the best place to put this slide, but we wanted to just do a bit of a touch point on special diets for children with autism. And my hope is that the case study really illuminated the food selectivity that is so common in this population. And diets are costly, hard to follow, and limit food variety even further. Autistic children with limited food preferences may be at higher risk for nutrient deficiencies if put on a special diet. And the American Academy of Pediatrics specifically reviewed gluten-free, casein-free diets and supplements, including omega-3 fatty acids, and really found there was no evidence that either had an effect on social interaction. Similarly, there's a Cochrane review, which is a format that does a big analysis of lots of different papers, and they similarly showed there's no change in outcome with mega doses of B vitamins. Next slide.
Hi, everyone. Thanks, Lisa. That was a great introduction to Alex, kind of our kiddo. Pivoting a little bit, we want to think about, when we meet our kiddos, we want to get a baseline to really understand where those feeding challenges come in. We want to think of all the different etiologies of why those feeding challenges started or are persisting. And so one of the questions we ask ourselves as our team is, does my child, or as the clinician, does my patient have a medical condition which could be impacting that food selection? Is that why they're choosing the foods they are? Is that what is kind of impacting their constipation issues that they're having or other GI issues that they're having? Their ability to self-feed or not self-feed, whether they're chewing or swallowing. Lisa kind of touched upon this too, kind of that all those muscles that take place to kind of chew and swallow the tongue. What is at play, and is it a medical condition that we also have to consider? Next slide. Oh, good, thank you. So thinking about partnering with your entire care team, if we think about Alex, he, had OT already, he had an RD, he was working with his pediatrician, and they were all trying to work on all of those feeding issues that they were seeing. And so in our clinic, or when we think about what the medical team might look like for our kiddos, we want to think about both the medical side and the community partners that are at play. We try to remove those silos so that we're getting kind of a 360 approach at treating these kiddos and making sure that we are connecting with all those really valuable players. So when we think about the medical side, it's the pediatrician. They might be the first line defense of kind of noticing feeding challenges or delays, and they might have even been the ones to recommend kind of a feeding therapy. Pediatric gastroenterologist, which may be someone you're already working with based on some of those GI issues that are very common for our kids, or maybe that's something just like Alex has been recommended, but we haven't established yet. The allergist to think about environmental or food allergies that could be impacting kind of their feeding process, as well as a registered dietitian nutritionist, which is our role when we think about meal, not only quality and quantity, but thinking about that hunger piece, thinking about that meal timing piece, thinking about kind of the whole picture about food, plate, and in the environment. And then, of course, there's the speech language pathologists and the occupational therapists that are really going to help with that chewing, that swallowing, that fine motor skills. We'll get into that in just a minute. And then your community partners, which there are some overlap. You see the OTs or the SLPs there as well. You might have a social worker, or we might recommend social work just to kind of connect to community resources or other resources that could really be helpful at supporting kind of that feeding transition or those next steps, connecting to different services that are out there. Naturopaths are something that some of our families like to work with, and we like to kind of partner with them, or at least know what the recommendations are made across the board. And then, of course, we all went through a year and a couple of months of maybe stay-at-home learning. But as we get back into school time and daycare, kiddos will get, lunches and snacks there, and thinking about the environment that can be really supportive as well at the school and daycare, we, can be partnering together with the medical team and other community members to kind of have an all-around approach. Next slide. So thinking about the occupational therapist and the speech language pathologist, Lisa already did a good job of kind of introducing them, but they really kind of look at the other factors that, again, may be playing into why that feeding relationship is the way it is. So the swallowing function or the aspiration risk. Basically, the aspiration risk means, like, is the fluid getting into the lungs? And what changes can we make to make feeding not only pleasant for that kid, but also very safe? Oral motor feeding skills, so tongue, muscle, teeth, all that. How is that working to kind of swallow the food? Sensory awareness, the smells, textures, the look of a food. How is that impacting feeding? The gross fine motor skills, so using a utensil, using a cup. Positioning and environmental factors. So kind of, where is that eating happening? What does the body look like? And what are the other factors that are playing a part in kind of that distraction or the impacting the experience of mealtime or eating times? The OT and SLP can both address oral feeding. Each has a different area of focus and expertise, which I'll leave for you guys to read through. I'm not going to read through that right now, but it's really thinking about why these are important, players in that medical team. It's because we want to help progress feeding in a very safe way. And we also want to address the individual needs of each of the kiddos. We could have 2 or 3 kiddos come in with a similar diagnosis, ASD, feeding difficulty. They might have other things that are similar to each other, but they're different people and may have different needs within that spectrum. So we want to make sure we're addressing and progressing in an appropriate way for that individual. Next slide. So the gastroenterologist, constipation has kind of come up quite a bit. It's a very common issue, GI issue for our kiddos. And so kind of being able to address that and how that impacts the feeding relationship is an important kind of first step, and sometimes an ongoing step. Abdominal pain can also come from that, or maybe another piece to that as well. IBS is something, as well as some other GI diseases, can also be part and parcel to what's going on with the kid. And so it's great to have the GI professional, the medical professional there to have those conversations and to be able to address what is the core etiology of some of these symptoms that we're seeing. Is it just constipation, or are there other factors at play, such as reflux or, other things? And that's why we get baseline labs if we can. If able, we love to get labs to see what's kind of happening right now. Like, we want to look at certain nutrient deficiencies. I think Kim was mentioning, there's very common nutrient deficiencies based on those selective eaters, because of the foods that they're choosing. So kind of having an understanding of what those are and what we need to kind of address with each kid is helpful if we can get that. And this is also something that the MD and the RD will partner together to see kind of where those labs lie or what ones they need. They will also sometimes get labs to rule out or confirm whether there's inflammation at play, or maybe another disease such as like celiac disease or IBD or IBD. And then G-tube feeds, these are sometimes things that have already been placed or may have a recommendation to be placed. And what they're really there is to support ongoing oral feeding. It's a way to kind of remove some of that ask if it's needed to be supported. And that can be just from hydration standpoint. There are kiddos that it's just really challenging to do that orally, whether from a safety perspective or from like a function perspective, or just from kind of that, that feeding disorder perspective. So sometimes the G-tube is needed to meet hydration needs. It could also be there as a way to completely meet the nutrition needs, like maybe someone's on all formula at this time, or maybe it's a part of a formula, or maybe it's even like blended foods and they get part of their nutrition that way. And then there could just be a need for the medication and vitamins to make sure that we're consistently giving that in a way that's easy and kind of supportive of what's going on. Or maybe it's all three or a combination of two, but sometimes that's needed as just a way to kind of move on. And then I kind of already mentioned this, maybe there's some medication intervention that needs to be made, and that would be kind of the MD's role. They would prescribe constipation management to help make sure that that constipation is not impacting that hunger and satiety piece that Lisa kind of got into with our Alex kiddo, or kind of to manage the reflux symptoms that can be part of one of the reasons why kiddos are nervous to eat. Next slide. And then the other piece that we know is really helpful for the constipation is hydration. We want to kind of use both caloric fluids like milk, or, it depends on, where the kiddo is. It could be milk, juice, even sometimes Gatorade, soda, depending on what they'll accept at that time. It could be formula, or it could be non-caloric sources like water, or some other flavored beverage that doesn't have calories to it, but kind of using that along with medication, or kind of instead of medication, to see how that kind of works together. Next slide. So as a dietitian, so if I was to say, meet someone like Alex, I think we've gotten a great introduction to him. When you sit there, you want to know, okay, what is our baseline? What is our foundation? Not only is it to understand what that feeding relationship is from all the way back to, infancy to where we are currently, but it's kind of figuring out what is that current, where are those foods that they're okay eating? So it's working together with family, or with family and kiddo to say, okay, what are your preferred foods across all food categories? It might just be, Pediatric and Goldfish. We might have 3 foods in 2 of the, food categories, but we don't really have much in the others. Or maybe we had some before. We had, turkey in the past, but we'd stopped eating it a month ago. We stopped eating it a year ago. All of those things are really good to kind of have down so that we know where our next steps with treatment are going to be, and how also to build out a balanced meal using those preferred foods. So together we'll show you our chart later, but we'll kind of build that out together. And then through that, we will use the foods that are currently in their wheelhouse to build out balanced meals and work on that meal pattern. Thinking about using that hunger to really drive change and drive satiation, and drive the feeling of being able to do it, being able to eat enough, and really eat to a volume that's going to be satisfying for themselves, and be able to wait and not have to go back. And we'll talk more about that hunger piece in a minute. And then we also want to think about how long are meals taking, when from start to finish, right? How long are meals taking? Are they eating most of their, things at first, and then this one thing takes an hour to 2 hours, and then they're still, working on it, and we might be starting out at that place, but we're working towards a goal of 30 minutes to kind of use that as a way to eat enough to be satisfied, because what we found is that that is a reasonable amount of time for kiddos to use to eat enough to satiate themselves. But we have to sometimes use our behavior providers to help us get there, right? We need to work towards that and kind of set, up a foundation for that too. Because we want to focus on the benefits of feeding a child what they will eat instead of what they should eat. And we can have those other foods that we want them to eat, but we really want to honor and know where they are now and use that to our advantage to build out that hunger. Next slide. And part of that is using this plate model. So really focusing on kind of that one plate situation. And that kind of pulls out a lot of those food categories that I was just mentioning. So we think about the protein entree. Maybe that's a Uncrustable, okay? And then we think about the starches. Okay, maybe it's a goldfish. And then we go on to the fruits and veggies. Maybe they do actually have like, oh, I'll take some fruit in a pouch, and we can use all those things together along with milk on the side, or a milk alternative, to kind of think about that is going in this combination going to be enough to satisfy our kids. And we work very closely to think about what that portioning looks like and how much that body needs. And that's, again, very individualized, to make sure that that is a satisfying meal for them and that they can sustain that for a little while until the next meal. So it's kind of by putting all those different pieces together, we can make of, maybe it's Pediatrich and goldfish right now. Like I said, maybe those are the only two we're working with, but we're doing it in a way that's going to be a satisfying meal for that kiddo until we can kind of continue on. Next slide. And in thinking about those kind of different categories, one of the reasons why it's a combination of different food groups is because of that satisfaction element. Orienting you to this slide. So basically the bottom, that dotted line, is where we're starting to feel hunger. Our stomachs are growling. We're ready for food, right? Our body knows, okay, it's time for eating. And then the y-axis is kind of that satisfaction, like how quickly do we get there? And then the x-axis is kind of how long does that sustain us? So if we think about the sugars, they're going to satisfy us really fast, but then it drops off really fast too. Starches are similar, right? You're going to get there, and you're going to get there pretty quickly, and it might last you 15 to 30 minutes, but it's really not going to last you very much longer than that. And that's where maybe sometimes kiddos are going back to grab more, because not only is it their preferred yummy crunchy, but it's also not giving their body enough to really feel satisfied. So it's when we can add in those proteins and those fats that can kind of not only extend the amount of time that we're feeling satisfied, but also slow down the digestion process enough so that all of those things are kind of working together to make us satisfied for a longer period of time. Next slide. So thinking about meal patterns, so I gave a bunch of information about plate makeup and foods that kind of make us satisfied. And this is kind of thinking about the different meal patterns that could kind of come up and things to work on, or things that we see when we're kind of talking about foods that kiddos are eating or the way that kids are eating. So this first column on the left is really kind of giving that presentation of like 3 meals and 3 snacks, or maybe even based on the slide or the circles, it looks like maybe even 4 meals and 2 snacks, something that kind of is spaced out throughout the day. And what that does is it helps us present food when kiddos have optimal hunger. It helps them be interested in a little bit more than just maybe only their favorite foods. And it can help them feel satisfied. I can reinforce, okay, I'm hungry, I'm going to eat. I can eat for a volume that makes me feel a certain way. And then that helps them meet their calorie needs for growth consistently. It can also help with that stooling piece that we were talking about with the constipation. It can also help by having a consistent meal pattern. It's shown that that's actually helped with that process. And when we are not super hungry, we can sleep better. If we've satisfied our body's energy needs throughout the day, then we can kind of sleep better at night. And they might not wake up just like Alex would for milk multiple times a day. if we look at that second column, that's kind of our classic presentation of just kind of grazing throughout the day. And I think one thing that was mentioned earlier was, we want to make sure, what I hear is I want to make sure my kid's eating enough. I give them, if they say they're hungry, I let them grab food because they're hungry in that moment. I want to make sure that they're eating something. And so that's kind of our second picture. Like, they are grazing, they're eating small volumes, they're doing that frequently, and what this really does is it reinforces eating for that flavor, that yummy crunchy. They're going for the yummy food that they typically want to go grab. But what we saw in that previous slide is that's not going to satisfy for really a very long time, or our mouth is like, oh, I want more of that yummy crunchy. And so we go back and that pattern kind of repeats itself. But we may not be, in that sense, since we're eating for taste, we're not really eating for hunger or satisfaction. So that kind of reinforces that desire to not maybe go beyond that. We're eating enough just to kind of get that, and then we're going back down, and then we're eating enough just to be kind of a little bit satisfied, but it doesn't last for a long time. And then this third column, this is our kiddo who wakes up, they may not be very hungry, and then they eat a little bit of something. And then this long space is kind of maybe school. Maybe they go to school and they don't have any kind of long amount of time to, or they don't really like to eat at school. They don't eat at school. So they kind of have this long space of no eating. Then they come home and then they're hungry. And so they have maybe a little bit of a bigger snack. And then that satisfies them for longer. And then next time there's kind of this longer space, and then there's dinner, and then they're really hungry. And this is where they get most of their energy for the day. They just eat until they go to bed. And then they just have this large amount of quantity right at night. And then that repeats itself, right? They don't wake up hungry. And then this whole cycle kind of repeats. And what that's showing, this kind of irregular patterns of restriction and then overeating, or maybe even a little bit of grazing, leads to potential weight gain, which I think Lisa mentioned. I think it was 1.6 times greater than the typical population that ASD kids can be above weight. So this can lead to that, or this can contribute to that. And then, I mean, if you put all that food, sometimes that can cause a lot of that stomach discomfort, or even lead to vomiting, or cause some of those reflux symptoms that the kiddos are having. And by thinking about, okay, I'm going to get all my calories at night, or I'm going to get all my energy at night, then it kind of reinforces ignoring when our body is going to get hungry. It kind of says, okay, you can wait until later, because that's when you're going to be eating. You're going to be maybe watching TV and sitting in your favorite spot and having your food. And that's when you're going to eat, instead of really going, oh, my body's hungry, I'm going to eat now. And then it kind of ignores that. And then it can ignore satiety, because then it just keeps eating, right? They keep eating, and then they're not really stopping when they feel that satiation. Next slide.
So let's take the slide that Lauren just shared with us and think about Alex again. I circled the middle two patterns because he is really displaying a combination of both patterns. And so his earlier part of the day is more presenting as the pattern on the right. He has a small amount of calories in the early part of the morning. And then he goes to school with really very minimal intake, eats a little bit when he gets home, takes a nap, and then he kind of flips over to that left side where he's grazing. And just like Lauren described to us so well, he's not able to eat enough at any designated time to satiate himself. And often that's because he's eating small amounts of perhaps a dry crunchy. And we know from the graph that Lauren showed us, dry crunchies do a really, really good job of giving us that immediate short-term satisfaction. But it's difficult to sustain satisfaction or rest for 2.5 to 3 hours on just a dry crunchy alone. We would need a little more substance. Or perhaps he's having some of his Pediatric, but the volume is inadequate such that he's again able to tolerate that break in eating. And kiddos like this, like Lauren said, never really get hungry or they never really get full. And so just in terms of the biology or the biological motivation to come to the table and eat, that's not there. And I think it's really important to emphasize that biological motivation is really only one piece of the pie, like we saw on that first slide, but it is something we think about when we're thinking about feeding therapy, because timing matters. Next slide. So the first thing that our team did to help Alex, and I think it's important to note the child needed behavioral support to implement this plan. But the first thing was to establish an eating pattern with balanced combination of solids with a calorie balanced fluid, something he was willing to accept. And then again, a volume that was reasonable and age appropriate for him to eat in 20 to 30 minutes. And this was done across regular intervals throughout the day. And in between, you'll see it'll show up on a later graph, water or a non-calorie fluid between meals and snacks, just to help them with hydration. We also coordinated with medical team, and he was given Miralax to help resolve the constipation. An alternate might be a source of fiber from fruit or veggies regularly as a part of meals 4 to 6 times a day. Next slide. And kind of a little detour, but what we all use as a tool in our clinic and think can be really helpful is kind of the application of what Lauren was sharing with us earlier in terms of first steps that we recommend to patients and families in our clinic is really getting a good baseline of foods that your child or the children we work with are willing to eat. And we break those out by food category. So proteins, entrees, main dishes, the first category. The second would be starches or grains or carbs, then fruits and vegetables, desserts, condiments, and drinks. And we think about drinks that have calories and drinks that don't have calories. Both can work together to help with functional stooling and to resolve any concerns around constipation. And then we really think about, based on those food categories, like how often does my child eat this? Is this something that I can put on the table and 80 to 100% of the time I know it's a safe bet that they'll accept what I've offered? Or is this a sometimes food? Is this kind of a 50-50? And those are the two categories that we start by focusing on. The third one is foods that my child used to eat but may not accept anymore or is refusing. So this is available on our website through the Autism Center. If it's something that you're interested in downloading, it's free to download. But I think it's a really helpful visual just in terms of really digging into that balance piece again that Lauren showed in a couple of slides, first with the Ellen Satter graph and then the second with the My Plate, because it's very individual from child to child. I also think it's just worth mentioning that we see a lot of kiddos where that fruits and vegetables category is completely empty, and that's okay. That's an okay place to start. But we really want to build on what the child already will do and sort of go from there. Next slide. Going back to Alex's meal plan. So in the long term, what we think about is really how to build balance into every eating time, again, to promote satisfaction and the child's ability to tolerate 2.5 to 3 hours between eating times. And for Alex specifically, just the way his day worked out and based on parent capacity, that was 5 eating times a day. For some kids, it's 6 eating times a day. I would say it sort of just depends on the child and the child's needs in terms of total calorie intake and their ability to intake an adequate volume at any given eating time. But what you can really see from this long-term meal plan is the timing is the first thing. So meals are spaced every 2.5 to 3 hours. And then the solids are balanced across different food groups. So protein entree with a starch and a fruit or veggie, fruit for breakfast and then fruit or veggies for the other meals. And then fluids. And so we are ensuring that he gets enough to help with stooling. And also we found that it's really difficult for most children to meet their calorie needs exclusively with solids. And so getting between 20 to 30 to maybe up to 40% of their total calorie needs from fluids can be really helpful just in terms of maintaining growth if that's a concern. Next slide. And again, this is sort of how it translated just in terms of his meal plan. So putting that slide previous into practice, but noting this doesn't have the times. So we really are thinking about foods that Alex is willing to accept. These aren't new foods. These are foods that he's willing to eat reliably to moderately reliably. And we want to honor rotating the less preferred foods at this time at a frequency that we know he'll accept. But so, for example, just looking at breakfast, his protein or his entree was a yogurt with a side starch being some dry crunchy crackers, and then some fruit slices, some apple slices. And at every meal, he's getting some calorie beverage. And so his chocolate milk that has a little bit of cream in it. Next slide.
All right, thank you, Lisa and Lauren. Those were really great slides you did there. We're winding up a little bit on this talk, and I do see that there's quite a few questions in the chat, so we'll be getting to those too. But I just wanted to mention a little bit on portion size, because I think families have a lot of questions about that when they're working with their children and figuring out, well, how much does my child really need to eat? And what is a portion size? And it does vary depending on age. So a child who's 12 years old, a portion is going to be larger than a child that's 2 years old. This portion size graphic is available, and I think that there's a link that's going to be provided for participants to download it themselves. But it just gives an idea of what a portion of a grain would be, what that might look like. For instance, like a cup of cornflakes is the size of a baseball. A pancake is the size of a CD, if we remember what those look like. I know a lot of people probably don't. If you go over to like the meat and fish and nuts category, you can see like 3 ounces of meat is like a deck of cards, or like 2 tablespoons of peanut butter is like the size of a golf ball. You might see over in the fruit and vegetable category that a cup of strawberries is about 12, so you can count them out. That can be a way to figure out a portion size. Or a cup of cooked vegetables, again, the size of a baseball. So these are just visuals that can really help. And sometimes it can also help to teach a child, if they're at an appropriate age, where they are learning these things as well, and they can relate to these items and how much that might translate into a portion of food. Next slide. Oftentimes you will have a recommendation for a vitamin to be added. These children who have very selective diets and very limited diets might benefit just from a general multivitamin. There are several varieties. A lot of the ones listed here are liquid. There are some powders. You might know of just regular like gummy type vitamins or hard chewable vitamins. And there are other vitamins that are like melty tabs, which are a newer kind that might work for your child. Next slide. in addition to a general multivitamin, your child may have specific nutrient needs for calcium, especially if they do not accept milk. And they may need something like vitamin D to go along with the calcium, or if there is a blood test that shows that their vitamin D level is low. We in the Northwest are at risk for lower vitamin D, and so that lab test is often done just to make sure that that is not something that we're missing. Iron is another one, and yummy iron. I know if any of you folks out there have tried giving your children iron. Some of the irons are not very tasty, and I haven't tasted this one myself, but this is probably a grape flavor. For some reason, the folks that make the liquid iron have decided that grape is the best flavor to mask the flavor of the iron. So you'll see that frequently. Next slide. So this concludes the presentation, and we can take questions now.
Okay, we received a lot of good questions in the chat and comment section. So I'm going to start by asking one of the questions we got towards the end of your session. And this is a question we get a lot at the Autism Center. The question is, I'd love to know your recommendations for what to do while we're waiting on the waiting list for the intensive feeding program. We're seeking help from multiple sources while we wait, but your program has a multiple year wait list. And from what we've been told, is that true? And there's really nothing that compares in the area. In the meantime, our kiddo is having a really hard time with eating. And panelists, you can decide who wants to answer that.
Well, I can start if you like. Hopefully your child has been getting regular feeding therapy, or there's a feeding therapist in your area, and also a nutrition person to kind of work with the feeding therapist. Those two people, along with you, can work together to come up with some plans in the meantime. As far as additional resources, and I'm not sure if this is happening right now with the pandemic, there was an online class for parents and caregivers. I think it was 4-session class that you can attend just to get some of these basics down before entering into the program. And another thing is if you're on the waiting list, it doesn't hurt to call or ask, like, well, where am I? And just kind of get an update as to the status of your child. Lisa and Lauren, do you want to add anything?
Hey, any other panel?
It's the class that Kim is thinking about is called Feeding First Steps. And like she mentioned, it's something that's available through the Autism Center. And the intent is really to take a deep dive a little more closely into some of the themes and topics that we have shared tonight. And just like Kim said, it doesn't hurt to call. We have been working really hard to reduce our wait list. It's a problem we're absolutely not unaware of. And every time I do an intake, it's hard not to want to take that kid on for treatment just right then and there. And so I would imagine we would feel the same about your child when we do get to that assessment, because it's complicated, and we really recognize that. So thanks for your patience with our team. We know it's a wait, and it's something we're working really hard to improve.
Thank you, panelists. I wanted to mention that on the Seattle Children's Autism Center website, under Family Resources or Autism Resources, there is a section on feeding, and we've gathered a bunch of resources and things that parents can do while they're waiting. This information was collected by the intensive feeding team. So resources, information, handouts, so check that out. We can post the link to that in the comment section. Okay, Very good. And as they said, do call the Autism Center, check the status of your wait time, and also see if there's a cancellation list you can get on. Okay, next question. This is, the question is, does the advice about strict meal/snack times, parentheses, eating 5 times per day without access to snacks in between, apply to autistic children who are selective eaters, but who do not graze? Example, eat more at meals and snacks and only snacks 2 times a day.
I think that's a great question.
That's written down too, if that's easier to.
Yeah, that's great. I think that's a great question. And I think we did touch upon the idea of why we recommend kind of consistent eating throughout the day and the different ways that can actually support GI function, sleep, energy use throughout the day. I think your question is good. I think thinking about what is that spacing, right? How long are they going without eating and what's happening in that time frame? And where are those adjustments that we can make? I think Lisa said it perfectly. And I think what we all take on is that there is no perfect. There is no there's no set schedule. We have to set a timer and go off of that. But we know by having that consistent eating throughout the day and kind of keeping to that 2.5 to 3 hour mark with spanning out eating can be really beneficial. It can help with behavior. It can help with hunger and satiety. It can help with moving treatment or just feeding forward. It can help with those GI symptoms like I was talking about and the sleep. So while, maybe it's not 6 times, maybe it's 5, maybe, we're expanding towards a different one, working towards a goal of kind of that consistent eating throughout the day.
Yeah, and I just want to say that it's probably, children in general need 3 meals and 2 to 3 snacks a day, evenly spaced out, 2 to 3 hours apart, just because that's the best way to nourish a child. Their stomachs are a certain size, and they do need to have small, frequent meals and snacks throughout the day. Not just autistic kids, but just all kids.
The last thing I would add to what Kim and Lauren said is just that often our children weight is a concern. And so we find that children like Alex, who are grazers, not specifically in his case, but common children in his situation, find it difficult to gain weight with a decreased frequency or more of a grazing pattern of eating. So by spacing meals to 2.5 to 3 hours, what we're really trying to do is optimize that biological motivation. And we know to best do that by giving children a reasonable amount of time. So we know from literature that most of us actively eat for the first 10 to 15 minutes, and then pace of eating kind of slows down by 20 minutes. And so, 30 minutes is a reasonable amount of time to get enough. And again, we've seen that really help with if weight or weight restoration is a concern or a consideration.
Okay, I will move on to the next question. This question is, my 3-year-old son is a very restrictive eater. He only eats chunky purees and smoothies. He has an autism diagnosis, speech delay, does not chew, has a tongue tie, and has always been in the low 2 percentile in weight. He has OT, SLP, ABA, and feeding therapy for a year now, with feeding only 6 months. But we haven't seen much improvement in his feeding yet. Any suggestions you have for me as a next step?
I guess it depends on what the goal is for the feeding therapy. If it's chewing or, moving to solids, or kind of building out more of a balanced puree plate. We do have kiddos that are strictly puree, who we then work within those pieces to then help them work with in that meal pattern to kind of think about it in the same way that we would with a solid eater, like a person who eats solid foods. And then for that chewing piece, for that those motor skills, that's where our SLPs and our OTs kind of come in to really work with the kiddos on making steps towards that. We have an SLP who actually do chew function with our kids. So I think depending on what your feeding goals are, we do have kiddos who are strictly puree. It sounds like that's who your child is. And then if it's hunger based or kind of working on that meal pattern based, we can absolutely work with purees, with those textures that they're really comfortable with, to kind of make a complete pattern and get them the nutrients. And then the SLPs and the OTs kind of work on chewing and the functional pieces to that. Kim and Lisa, is there anything additional?
Well, I do notice that their nutrition is not included in your list of providers. So maybe, getting the nutrition piece added can be of help with the specifics.
And I think that role would really be just helping to create balance within the context of what your son will do. And really just sort of being thoughtful about how do we make those purees satisfying and help with adequacy of caloric intake to promote weight gain. And I have a 3-year-old too. He helps me with my notes. He scribbled all over them. So thank you.
Okay, thank you. This next question is from a provider who serves the autism community. Are there some main labs that we should think about that maybe are usual deficiencies but should be checked in picky eaters?
I think that Lauren did a really nice job of listing off kind of that complete panel, and as she alluded to, because of the low diet diversity that we see in our patient population, we have a really low threshold for checking labs with our patients for concern of risk of nutrient deficiency. I think that common concerns that I have, and I'm often teaming with my medical colleagues around, are iron and iron study labs. We know that sleep in Alex's case was a concern. And as Kim mentioned earlier on, iron has been studied and demonstrated to be related to sleep inadequacy. So that's a big one that we really think about. We often are really concerned about mineral intake. And so we'll check a zinc, but if a zinc's low, we often know that can be representative of other minerals that we may not have the sensitivity of a lab test. And but if I see a low zinc, I'm concerned that other minerals may be low. Vitamin D is like the low-hanging fruit that we all live in the Pacific Northwest, right? So it's really common for us to check a vitamin D lab as well. Unless the child is being supplemented or eating a fortified vitamin D food, then it's not uncommon to see that low. And then from there, I would say it's really individual based on the patient in terms of concern and where there's kind of gaps in that diet diversity. But again, Lauren gave detail on sort of the whole panel of things we might be considering. If for a child that's higher weighted, it's pretty common for us to do a fasting glucose and a lipid panel, which is kind of just from our child wellness clinic colleagues, the recommendation that we've received. So yeah. And Lauren and Kim, please add.
I think you did a good job.
Yeah. Very good.
Great.
Wonderful, thank you. This next question is has to do with concerns around at what point should my child's picky eating be considered a more serious concern? So what are some signs or symptoms that, chicken McNuggets every day and that's it, or no vegetables and no fruit, which we know a lot of our individuals that are autistic really have selective diets. But at what point should parents or caregivers really think maybe there's something more serious going on?
I can start that question off. From a nutrition perspective, and again, I think it's always important to have a medical perspective as well when we're talking about the health of our children. So we're really looking at growth, adequacy of growth. Are they following their growth curve or kind of the trend that they've been on? And do we see changes or fluctuations to that? Are they changing growth channels, going up or going down significantly? I think about adequacy of intake. So is the child getting greater than or equal to about 60% of their calorie needs such that they're able to sustain growth? Adequacy of intake. And so that sort of is that diet diversity piece. Are they able to eat 3 foods greater than or equal to 3 foods across environments? So are they able to eat at home? Are they able to eat at school? Will they accept a multivitamin to make up for any sort of deficiencies that we're concerned about? Or is the child completely refusing any sort of supplementation in any of the forms that Kim talked about? Are they able to eat more than 1 food at once? Are they really only accepting 1 food at a time and sort of grazing such that there's concerns about overall intake throughout the day? Those are some of the, and also fluid intake. So is fluid intake low such that we're seeing really extreme constipation that's limiting a child's ability to satisfy or satiate?
Okay.
Kim and Lauren, anything else? Okay.
That was a very good and complete answer. Good job.
Okay.
Thank you. We have one more question, and we have a little time, so we encourage any additional questions in the comment section before we wrap it up. This question is, my son has limited verbal ability. Like a lot of kids with autism, he doesn't use his mouth much in the world. He doesn't talk much, so he doesn't use his face muscles and has low tone. Any suggestions to wake up his mouth or build muscle tone in the face?
Well, I can start with that. I mean, I do hope that your son is getting some oral motor therapy from a trained therapist, because that can definitely help. There are speech therapists and OTs that have PhDs or doctorates studying this and can really help a lot. So I do hope that your son is getting the help from a qualified therapist. What I would tell you is what I've learned from working with them. So there's a lot they can do. That's all I can say.
I would echo Kim. I think that's an excellent opportunity for us as the dietitians to coordinate care with our OT and SLP colleagues. And that's an area where we would coordinate care. But as far as the scope of the dietitian, I would say that that work is outside of our clinical practice area.
Mm-hmm. Yeah, I know we can work with our behavior providers
Thank
too
you.
on just the communicate. Oh, sorry, can you hear me? Okay. No, I was just saying, as a communication factor, thinking about eating and being able to have that communication. Sometimes when we do have our limited ability to communicate orally, that's where our behavior providers come in, and they kind of help work with other ways to communicate with pictures and things to kind of help build that trust and build that relationship in with food. So it's not necessarily your muscle tone or anything, but that's just another way to think about how that relationship can be built through a different form of communication. And that's typically, it's out of our scope, but that's why, again, we love to work on our team, because they are so skilled and so amazing and have so many different ways to build that feeding relationship out. And I think it's called PET. I can't remember what the acronym actually stands for. Picture. Does anybody else know?
Oh, well, there's so many communication devices. If your child is challenged with communication, pointing at pictures, there's, even like boxes where you can point to things, and kind of like an iPad sort of a thing. And there's all sorts of things that can help with communication.
Picture enhanced communication. Thank you.
There you go.
Came up to me.
Thank you. Actually, it's picture exchange, but it's called many things. But that's thank you. Yeah, a lot of the kiddos are doing that. Okay, so could you tell us a little about PET communication or PET communication?
That was basically I can't go beyond that. It was more just that there are other ways to communicate feeding needs or feeding desires that are nonverbal, because that is sometimes a challenge with our kiddos, as was mentioned. So not only does that impact the chewing and swallowing abilities, but the communication at the table for more if they're hungry, right? We want to honor that. Or if they're all done, how do they say that, or how do they communicate that?
And I think that's a really important point.
Thank you for that.
In our children that we work with that are nonverbal or aren't able to adequately communicate hunger, we want to be really, really thoughtful about the total calorie volume that we're offering at any certain time, so that we're not reinforcing eating when our body doesn't feel hungry, and at the same time we're not stopping the meal or ending before they're finished. And so that's where that meal plan that we showed for Alex can come in really helpful, and that's an opportunity for the dietitian to kind of contribute to the team.
Thank you for that thoughtful answer. And I think it was a typo. We were talking about picture exchange communication. Thank you. And there's many other forms of nonverbal communication and tools for augmentative communication. So thanks for that great answer. We do have another question here. Do you have general advice for kiddos who have both ASD and celiac or other diet restricting medical issues? It makes eating so much harder.
It does. I think this is why having the GI provider on your team to be able to make sure we identify those limiting, those needs, those diagnostic needs, so that we can then work very closely with families to find foods that are both not only, accepted, but also safe for their body based on their diagnosis. I don't know that I have general advice. I think that's why it's really, I guess my general advice would be work with a registered dietitian to be able to work with your family to find those foods that are helpful. Because they're actually, with celiac disease, there are a lot of gluten-free options that are out there that can still be well accepted in our community and working with our behavior provider. So it's almost a benefit to know what that diagnostic need is, so that we can better address the feeding relationship and the feeding needs of that kiddo. So general recommendation is as working with an RD. And if you can't, just thinking back to the question about not being able to get into our clinic immediately, working with another, either a GI dietitian, working with a dietitian in the nutrition clinic, so that you can at least identify a variety of foods that might be helpful to focus on. And then again, putting those in the different categories, just like we were talking about, using it in the same way that you would any other gluten-containing food, to make sure that it's still fitting into that starch category, or other categories, and it fits into that profile for the complete plate, that balanced plate. I'm all done.
Thank you.
I agree.
Adding on to that question. Sorry.
Oh, I agree. I would just say,
there was a
echo that. I agree. It's a hard thing when there's a medical medically indicated limitation because we're really working with low diet diversity to begin with. But like Lauren said, we are really just focused on preferred or accepted foods within the context for that child. And we recognize those may be even further limited. The child maybe would accept more foods if gluten were on the table or whatever the allergy limitation is. And we still really focus on kind of the balance piece within the context of accepted foods. But it's hard.
It's hard. It is hard.
But it's more important to know these things
Adding on
than to not know them.
Agreed.
So we have one
We have time
additional
for one more
question that's
question.
an add-on to this question. We just did. Yes, one more question. So adding on to that, how do you address anxiety and how it affects eating issues in autistic kids in your clinic?
We're very fortunate in our clinic to work with some really phenomenal behavioral providers. And so often their expertise as clinical psychologists is overlapped with our work. And so we're able to address anxiety. And I would say it's our psych colleagues who are addressing it. I would say that outside of that, it's not uncommon for our kiddos to have an outside therapist or a community-based therapy that's really more focused on the anxiety as well. But like I was saying earlier, our role on the team is really just to help reinforce that biological hunger and adequacy of intake. But at the very beginning, I had mentioned, but we know that that the psych piece is so huge for these kiddos. And like we saw with Alex, there's a long-standing history of aversion, which has been reinforced over time and time. And so that psych behavioral piece is really, really foundational to the success of our treatment and outcomes.
So just to add on to that, I think we all recognize that children that have feeding issues or sensory issues have anxiety around food, especially foods that are not familiar to them and foods that they aren't currently eating. So there are strategies for gradually introducing new foods and backing away if you need to, or if things are going a little bit better, moving a little bit forward. So that is definitely part of the whole treatment piece, is to recognize that the anxiety is probably there from the get-go. And it's how to help children become more comfortable around foods that they're not accepting, foods that might be challenging. And that's where it all comes together with our behavioral and our feeding specialists and our nutrition people, and our nurse practitioners help as well. And it's the whole team that holds that and helps move it forward.
I'm going to ask this question. Okay, thank you for that answer. Thoughtful, thank you. We have one more question before we close. We have a child that has become very overweight during the pandemic. He has very limited palate. We are struggling to introduce healthy food choices. Are there any resources for how to introduce new foods? Is there something that should be addressed by his OT? We are new to ASD.
Well, I can say something to that too. OT can definitely help with that. There are other resources available. Actually, I don't know if I'm allowed to encourage a resource just by saying it. There's a new book that's been out by an expert in the field of OT. Her name is Marcia Dunn Klein. She just wrote a book called Anxious Eaters, Anxious Mealtime, Support for Seriously Picky Eaters, which I haven't read the whole book yet, but I've read an article about it. And this particular person has a website that you can also Google her name, Marcia Dunn Klein, and get a lot of resources just on introducing foods, working with anxiety with picky eaters. I would recommend that as a really good resource.
Okay, anybody else have any comments before we close?
I would just add one last thing. And I think it's just a question of kind of goals of care. I think Kim's reference to Marcia and Klein is an excellent one. If the goal is focused on weight management or wellness, I think that considering a referral to our child wellness clinic could be another option. They're very comfortable working with children that have selective eating, and the wait list is not comparable to ours. It's not as long. So if the goal is kind of wellness or weight management, I would steer you that direction. If it's really the introduction of novel foods, then again, that's something that we do in our clinic, but agree with Kim's reference as well.
Mm-hmm. And I actually have heard that it's not just children who have gained weight during the pandemic. So being stuck inside, having less activity, being bored, unfortunately, it's happened to a lot of people, and it's something that all the health professionals are going to have to address as well.
Okay, thank you so much. Before we close, I would just like to thank Kim, Lauren, and Lisa for sharing their expertise, their passion for this work, their love and concern for the autism community, autistics, and those of us that care for individuals with autism. We want to thank you so much for your great work. Remember, this presentation is viewable following this presentation tonight on Seattle Children's Facebook, and also in about a week or so it will be on Facebook, it will be on YouTube on the Autism 200 playlist. So before we do close tonight, I just have one quick shout out to someone who's spent a lot of years and energy and great work for our Autism 200s, and that's Stacy Andrews. Stacy is moving on to another job at Children's, but she's tireless energy and wonderful support for our community through all her great work behind the scenes with the communications and marketing and social media involved in this event. So Stacy, thank you on behalf of all of us. All right, we are going to close out the session, and thanks again to our panelists. Good night.
Thank you very much for having us.
Good night.
Bye-bye.
Bye-bye.
Good night.